Welcome back to our series on menopause. In today's episode, we're diving into one of the most talked about and often misunderstood topics in menopause care: symptom management and hormone replacement therapy. From hot flashes to sleep disruption to mood changes and brain fog, menopause symptoms can affect every part of daily life, but effective, evidence-based options exist. And joining me now from the CU Anschutz College of Nursing, certified nurse midwife and Menopause Society certified practitioner, Dani Balinski. Dani, thanks for joining us again today.
Of course. Nice to see you. Happy to be here.
I know. Glad you're back. Okay, we want to talk today about symptom management, specifically hormone replacement therapy. Let's just get right to the basics. That's what everybody wants to know. What is HRT and what is it typically used for during menopause, perimenopause, etc.?
Sure. HRT or menopause hormone therapy generally is referring to the use of some sort of estrogen with some sort of progestogen, which could be like synthetic progestin or a bioidentical progesterone, in order to treat symptoms of menopause, generally hot flashes, night sweats. And the first thing that we kind of need to decide when we're working together to decide if this is something that someone wants to do is, does a patient have their uterus still? Because as we've discussed prior, if you have your uterus, we definitely need to use some sort of progestogen to protect the uterus from the thickening of the endometrium that comes from the estrogen. Generally, what my patients are using is a bioidentical micronized progesterone, which is taken orally, usually at nighttime, because it helps to promote sleep, although there are other options. If someone has a really hard time remembering to take this, we could place an IUD. There are patches that actually have synthetic progestins in them that can be absorbed transdermally. So there are some other options. Then we have to make a decision about, what sort of estrogen and what dose. And so your age, kind of your symptoms can kind of guide us at the best guess. And some people will, want to start low and slow, and other people are like, give me something that you think is going to work right away, and we can always come down. And what I'm generally starting with in my practice is a transdermal patch, because you can apply them once or twice a week. They are, not something that you need to remember every day, and the transdermal route offers some additional, we think it's lower risk for some of the estrogen adverse effects. However, there are other options if someone is not able, say you have like an adhesive allergy and you're not able to use a patch. We do have other options, including gels, sprays, and even a vaginal ring that can be a good option for people. So it really can kind of depend on your lifestyle, kind of like how the rhythm of your day goes. Are you in a pool every single day? Different things of that nature we'll consider as we're trying to figure out what is the best method. We also have oral estrogen pills, which can be something that is familiar if you're used to taking a birth control pill. However, we do think that potentially the transdermal preparations might be a little bit safer. And so if we can control your symptoms that way, that's generally what I recommend for folks.
And I know some people like to add testosterone. Women do have low levels of testosterone in their system. How does that work? And then what are some of the benefits people experience from that?
Sure, certainly. All people have testosterone in their bodies. And I think the big difference between the estrogen and the progesterone and the testosterone is that there's not a big and precipitous drop at the age of menopause as there is with the other hormones. And so if someone comes to me and wants to try it, our evidence-based indication for testosterone is for hypoactive sexual desire disorder. And that is actually diagnosed based on low sexual interest over a period of more than 6 months. And it has to be distressing for the patient. And so if someone meets that criteria, we do have data to suggest that testosterone supplementation will increase the number of satisfying sexual encounters in a given month. Sometimes people will also just want to try it for building muscle or general energy, and we definitely don't have as much data for that, especially if we're going to keep you at the range that is physiologic for women. Of course, bodybuilders use testosterone, right? But they're using testosterone at levels that would have what are generally unwanted side effects for women. Receding hairline, deepening voice, growing hair in places that you might not normally have it, even irreversible enlargement of the clitoris. And so we want to be really careful that we're dosing this in a manner that is appropriate. And so before we would prescribe testosterone therapy, we would explain that for women, this is kind of like an off-label. We would talk about the risks and benefits, decide together if we think that's something that makes sense, and also check a testosterone level. I know we've been talking about how there isn't necessarily a level of circulating estrogen that would predict if someone is going to have night sweats or hot flashes or anything like that, so we don't usually use hormone testing to dose those things. But for safety, we do need to kind of know where your baseline testosterone is and know what your dose is so we can kind of predict where you're going to end up. If someone, hearing all that, decides that they do want to use testosterone, we have a couple different options. We can use a male-dosed product, which is an FDA-approved formulation, but for men, and dose it at about 1/10 of the male dose. And so they can come in little tubes or little packets, and usually we would have someone use a 1/2 milliliter or 5 milligrams daily. And you can use this topically as well, rub it on the inside of your thigh. And each little packet, where a man would use like the whole thing in one for every day, one dose at the male preparation will last about 10 days for women using it for this treatment.
Okay. What have you heard from patients, or what are you hearing when it comes to maybe some of the benefits that your patients feel when they go on estrogen, progesterone, and then even adding in the testosterone?
Certainly. There can be a wide range of benefits as well as a wide range of side effects. And so if we're kind of like working through this process, generally we will not start everything at one time because that makes it really hard to know. Is this a side effect from testosterone or is it from estrogen? We also have like certain clues that we think we might have gone too high on the estrogen, or if you're having irregular bleeding, there's different ways that we could dose progesterone to try and help with that. Are we going to take it cyclically? Are we going to take it continuously? So there is a lot of nuance in what's going to work for any given person. But certainly we've known for a long, long time that hormones help people feel better in menopause, especially if vasomotor symptoms are their main concern.
Let's talk about the concept of the window of opportunity. So when is the best time to start HRT and then potentially end HRT?
That's a great question. We do know from various studies that there is a period of time where using hormones for menopause treatment is the safest, and that time frame is generally within 10 years of menopausal onset, or people will kind of like say like age 60 or less. There's nothing like magical about age 60 necessarily, but that is like generally about 10 years from menopause onset for most people. And so, talking with your specific provider and making sure that you have your, menstrual history as well as symptom logs. And the reason for that is once you are kind of past that, what they do call window of opportunity, studies have shown that some of the kind of scary things that we worry about, mainly like cardiac events, stroke, is actually higher if you start to take hormones. And generally that was shown in the estrogen plus progesterone arm of the WHI trial, which we're going to talk about a little bit more in detail, has a much less favorable risk-benefit profile.
Talk about bioidentical HRT. That is kind of the new catchphrase out there. So how does bioidentical HRT impact women in regards to the patch, as you were discussing, versus the pellet? A lot of people are talking about the pellet now.
Yeah, and so bioidentical, all that really means is that a molecule has the same molecular structure that your body's own hormones have. And so I think the kind of reason that this gets brought up or kind of caught on in the way that it did is some of the older studies were not using a quote unquote bioidentical hormone preparation, whereas now we do have even FDA approved. The majority of the hormones that I'm prescribing people who that they can get through their insurance and through their regular pharmacy are bioidentical, either estrogen or progesterone. That said, we use synthetic estrogens and synthetic progestins all the time. The majority of birth control pills are synthetic. There can be some advantage. For example, if you're someone who can't tolerate progesterone PO, or by mouth, we don't have a great option for people that's transdermal because of the size of the molecule. So we have some reasons where sometimes that might be a preferred option for some people. And we know that they all treat symptoms of menopause in similar ways. The question is, are they potentially a little bit safer? And we don't have great data on that yet. However, a lot of my patients do come in asking for this and prefer it. And it's awesome that we have bioidentical options that are going to be covered by your insurance, that we know the FDA has verified that they're going to be safe and what they say they are. Another thing that people will sometimes mean when they say bioidentical is that they're actually asking for what we call compounded medication. And what a compounded medication refers to is something that's usually made in a compounding pharmacy. And this can often be a mix of like custom hormones. And the issue with that is no one is really verifying what is in those medications. They're not subject to the same like rules and regulations that the medication that's dispensed at, a regular pharmacy is. And so we have to really be careful when we're looking at safety for those preparations, especially when we have government regulated bioidentical hormone preparations that we can use. Some other examples that can be concerning would be pellets, and those are not recommended by any professional society or organization. And the reason for that is once you put a pellet in, you can't take it out. And so if someone has these really, really high levels of whatever hormone, there's not much that we can do about it. And we have had people come in, especially with testosterone pellets, who have very, very high levels of testosterone, supraphysiologic is what we call it. And that can lead to some of the side effects that we've prior discussed, as well as just be dangerous for your system. I would much rather, work closely with a patient to come up with a hormone preparation that they're going to be comfortable with. And we can definitely use things that are bioidentical, but we're going to feel confident that we know what we're giving, what the dose is, which is just going to make this whole process safer.
Okay. You gave an overview. Let's now kind of dig down deeper. What are the different types of HRT available today, like the patch, estradiol? And then how do they differ in terms of risk and benefit? So if I'm coming to you, what are some of the options you would give me, and what are the risks and the benefits of each?
Good question. So there are a lot of different options, again, for hormone therapies. The kind of starting point, again, looking at your lifestyle, figuring out what is going to make sense in terms of can you stick with it every day, right? Because if you're not going to be taking whatever we give you, you're not going to be seeing the benefits in terms of symptom relief. The different like oral estrogen, the patch, the gel, the spray, and the ring all show similar efficacy in terms of treating symptoms. So it really is more, what is something that you're going to be able to use and stick with and that works for you. The biggest difference between the transdermal preparations and the oral is that the estrogen that you would take orally is subject to something called the first pass effect. And this is the liver metabolism of the medication. And this is where we think that we might see some of the increase in clot risk come from, because as the estrogen is metabolized in the liver, your liver can kind of shoot out some more clotting factors that could potentially lead to that increased risk. And by using a transdermal preparation, we can largely bypass this. This is more of a biologic concept. We don't have a randomized control trial that has definitively shown this, but we think the science of why that would likely be the case makes good sense. Again, the goals for treatment using estrogen or progesterone kind of vary. The therapeutic effects of taking estrogen, regardless of the route, is going to be treating the hot flashes, treating the night sweats, treating vaginal dryness, and for that, we can even use the topical non-systemic estrogen if we need to, as well as preventing bone loss. Side effects or reasons that we might think that we might have gone too high on the dose is if someone is having a lot of nausea, breast tenderness, mood changes, headaches. If we increase your vaginal bleeding, all of those things might be signs that we've kind of gone too high. And if you think about your kind of normal menstrual cycle, those are sometimes symptoms that people will have around ovulation when their estrogen is high as well. It isn't a game of like higher is better, right? We need to just get to the level that is going to give us those therapeutic effects, but we don't want to go so high that you're having some of these other side effects, which is why we have you come back every few months and keep these journals so that we can kind of work with you to see where you're at. Progestins, whether we're using a natural progesterone or a synthetic progestin, the kind of main reason that we use that is just to protect the uterus. Some people certainly find that it helps them go to sleep, but that isn't necessarily like the goal. The main reason that people take this medication is because you need to be able to safely take the estrogen. And I will say that progesterone is a little bit trickier for some people. Sometimes people will report that they have a lot of tiredness, sleepiness, some bloating, things of that nature, especially taking it orally. And so that's a time when talking about like an IUD might be a really good option because that's going to work more locally and be less systemic. It just sort of depends on the person. And occasionally we'll have patients who are just really not able to tolerate any sort of progesterone or synthetic progestin. And we do have some interesting options for treatment. There is a medication that is actually a estrogen that is with a selective estrogen receptor modulator called benzodiazepine. And that medication, along with the estrogen, can be used and will still protect the uterus, which is good because, like I said, there are some people who just no matter how we dose it, no matter how we do it, they have bad mood side effects from the progesterone. And so the more treatment options we have, the more likely we're able to get you on a regimen that's going to work for. For testosterone, we don't unfortunately have a female dosed FDA approved formulation. However, as I mentioned, we will often use a male dosed product just dosed at lower levels. You use it topically. I'll have people rub it on their thigh, after they get out of the shower, let it dry for 20 minutes, and then we will continue to check labs to make sure that you are at a level that is going to be safe for your body.
Okay. So this is a big question. What are the most common myths about HRT that you encounter and how are you responding to them these days?
Yeah, I would say that we are at a time where there's been a lot more attention in the news, on social media, being paid to women going through their menopausal transition, which is amazing because we want people to know about their bodies and understand what's happening and understand that if they're having bothersome symptoms that are affecting their life, that there are good evidence-based treatments for them. But there are a lot of myths and kind of sensationalized news that I think is also existing in this space right now. And I would say kind of the biggest thing that I would want to say to people is like there's a reason that we don't just recommend that every menopausal person get on hormones, right? Some people don't have bothersome symptoms. We also don't have good data for using hormones to prevent diseases of aging, things like cardiovascular outcomes. The data is mixed in terms of if hormones are going to help or hurt. And until we can kind of clarify some of that, there isn't a recommendation for like every single person in the world to be on it.
How should patients approach these conversations with their providers regarding HRT?
So if someone is interested in trialing hormone therapy for menopause treatment, bring in your diary and symptom log to your provider. Make sure that you've got your data on when you're bleeding, if you're continuing to bleed, when that happens, and when you're having your symptoms, because that can kind of help us make sense of where you might be in your menopausal transition. If you're 1 year past that last bleed, you're postmenopausal, but we still want to know kind of how often are your symptoms, how many times a day, how many times a week, how are the rest of your health habits, all of that good stuff. And then a responsible provider is going to sit down with you and look at your personal history, family history, surgical history, all of that stuff, and talk about the risks and benefits for you specifically. And that's going to be different for any given person. And we're going to talk a little bit about, some of the studies that we take safety data and our knowledge of risks and benefits from, and how we can use that to keep people safe.
And I think it's good to know too that the treatment for menopause is different or could be different than perimenopause.
Certainly. And so if someone is still cycling, then one of the big considerations we have for them is actually if they need birth control. And well in your 40s, it is unlikely for any given person to get pregnant. It's certainly not impossible. As a midwife, I've delivered babies for women all the way up through, 50 plus years. And so that is certainly a conversation that we need to have. Do we need to have some sort of birth control? And how is that going to affect, what we're treating in terms of perimenopause? And also really looking at your symptoms to see if potentially we think that it might be resulting from more of the wide swings in your hormone levels instead of having overall low hormone levels, which is what happens when you're kind of past that last menstrual period. And the treatment can be quite different. That is something that I think can be very surprising when people in perimenopause come to see me. I'll be like, after listening to what you've explained, I actually think a birth control pill might be most appropriate. And the difference between a birth control pill and menopause hormone therapy is that a birth control pill is actually generally higher dose, generally synthetic hormones, and it actually kind of shuts down your body's natural cycle. But if your symptoms are being caused by the fact that your hormone levels are swinging along with your body's natural cycling, that can actually be very helpful. So it just sort of depends on where you're at and what your symptoms are. And that's why, meeting with a provider to talk through those things and keeping track of it is that's how we do this.
Great advice, Dani. Thank you so much. Next time, we're going to talk about correcting the misconceptions, exploring the evolution of hormone therapy, and we're going to focus on the famous Women's Health Initiative study.
Coming up next in our menopause series, we go deeper into one of the most controversial topics in women's health, the history of hormone replacement therapy and the study that changed everything. If you've ever been unsure or hesitant about hormone therapy, this is an episode you won't want to miss.